afternoon, everyone. I'm presenting a prospective cohort study on the role of low-dose atropine, 0.01%, in the progression of childhood myopia. The rationale started with believing that excessive accommodative efforts would lead to myopia, and if we inhibit accommodation, that would stop the progression. It was subsequently seen that 0.01% atropine had additional effects. It inhibits the cholinergic receptors in the cornea sclera, including the alpha-adrenergic, GABAergic receptors, which would subsequently inhibit the cell growth and proliferation and inhibit the progression of childhood myopia. We had a number of studies that we took inspiration from, starting from the ATOM-1 study, which was conducted in year 2003 for 1% atropine and RCT, but there was a lot of loss to follow up, and subsequent to that, ATOM-2 study in 2015 compared the efficacy of 1, 0.5, and 0.01% atropine. Since then, we have had a number of studies, and it had shown that ultimately the mean myopia progression with 0.01% atropine was approximately minus 1.38 in 5 years, and that in placebo eyes was the same amount in half the time, approximately 2.5 years. So it showed 0.01% reduced myopia progression by approximately 50%. We did a prospective cohort study in which we evaluated 100 patients for a period of 1 year, aged between 6 to 16 years of age, where we compared the efficacy of low-dose atropine with that of placebo. At each follow-up, we evaluated the degree of refractive error, the axial length, and the best-corrected visual acuity. We used 0.01% atropine sulfate, 1 drop at bedtime. We divided the 100 eyes of the 100 patients into 50 exposed and 50 non-exposed. And we took a range of myopia from minus 1.5 to minus 10 diopters. And we evaluated them 4 monthly for up to 1 year. And we evaluated axial length and refractive error at each follow-up. We excluded degree of astigmatism greater than 2 diopters, any other ocular or systemic abnormalities, and we excluded patients who developed any allergy or hypersensitivity to use of atropine. Our baseline characteristics between the exposed and non-exposed were fairly similar, where we had a mean age of approximately 13 years in both the exposed and non-exposed population. The axial length was comparable in both the eyes, with approximately 24 mm mean axial length in both exposed and non-exposed, and the refractive error was approximately 3 diopters. And at the end of 1 year, we compared the axial length between the exposed and non-exposed, and we found that the mean increase in axial length amongst the non-exposed patients who did not receive atropine was approximately 0.3 mm, and in that of exposed, which received atropine, was approximately 2 mm. So we had a mean difference of 0.11 millimeters, and the refractive error increased in both the populations, but the degree of increase was much more in the non-exposed of approximately 0.75 diopters, and amongst the exposed it was about 0.25. So we had a mean difference of 0.5 diopters in the 1 year follow-up that we did, which was statistically significant, and it accounted for a percentage of about 20% in the population that received atropine. It's a bar graphic representation where we show the increase in the refractive error between the two populations and the percentage change, which was much more in the non-exposed population. We drew a number of conclusions from our study where we found that 0.01% could effectively be used as a supplementary treatment modalities in childhood myopia. We had only 1 patient that had to be discontinued because of intolerable glare and photophobia. Rest, we did not have any significant loss to follow up in our study. And the percentage change in the refractive error was significantly higher in atropine group than the non-exposed by a factor of 20%. And if we extrapolate these values on a longer duration of treatment, it could yield better results. The progression occurred nonetheless, only the rate of progression was affected. This goes on to show that a progressive error is a prerequisite for starting the treatment, and it also consolidates its use in childhood myopia. And the percentage reduction was only significant when the degree of error was less, and it would further invalidate the use in high myopes.